Sorry guys, yesterday I kind of got abruptly cut off by a signal that said terminated because I have exceeded my time, and I'm like, I have not exceeded my time. It was exactly 1 hour and 5 minutes, and I apologize. These chapters 22, 23, and 24 are quite long. All right, so I'm going to basically start a little bit before where I left off, right, with the acute tracheobronchial obstruction, which, like I mentioned, aspiration is one of the main causes of some sort of foreign body, like babies, with like quarters or marbles. And it's most often in the right lung because the right primary bronchus is more vertical. And so when you inhale, it's going to go straight down. It's also larger. Whereas the left primary bronchus is more out of a 90-degree angle. So it is harder to get something to go into that direction. Also could be from a endotracheal tube that is improperly positioned. Laryngospasm. You might see epiglottitis, which we're going to talk about in just a second. Trauma swelling, some sort of blood clot, or a compression of the bronchus or trachea in like a tumor or enlarged lymph nodes. So it could be either partial or complete, right? So complete obstruction is obviously no airway movement heard whatsoever. There's going to be an inability to talk, so no chest movements. There's tachycardia, cyanosis, which, is going to be like lips turning blue, fingertips turning blue, and then it's going to obviously rapidly progress to unconsciousness because, of course, there's a lack of oxygen to your tissues. A partial obstruction is going to be have some clinical manifestations, including stridor. So you're going to have a person struggling to breathe. You might hear wheezing or nasal flaring. So nasal flaring is another sign that the person is struggling to breathe, right? You might see tachypnea, dyspnea, and tachycardia. And again, in the neck, another sign, use of accessory muscles, and cyanosis in a late partial obstruction. All right, so again, based on some clinical features, right, is your arterial blood gas, for example, is hypoxemia and hypercarbia, and then a chest x-ray with the location of the obstruction are two kind of clear signs of a diagnosis of some sort of tracheobronchial obstruction, right? So then treatment is get it out, right? If there's some sort of obstruction that can be removed, get it out, right? Back blows or Heimlich maneuver to expel the foreign body. You also may do suction or a tracheostomy, which is, going through and getting straight through the trachea, usually at that jugular notch, and then getting an airway established through there. Again, which may not help if the obstruction is not at like the level of the larynx. All right. Now, epiglottitis is a cellulitis or infection of, right, the epiglottis. And it's a subtype of croup, very common in children that are 2 to 4 years old. And most common organism that causes epiglottitis is the Haemophilus influenza type B, hence why there isn't a vaccine for Haemophilus influenza type B. All right, so epiglottis ends up looking very much like, think of your thumb. So it's like a thumb sign. So if you take an x-ray of a child in the, like a mid-sagittal x-ray, so from the side, you'll see the epiglottis, which normally is barely visible because it's quite thin, look like a thumb. It's gigantic. And so obviously that's going to block the airway, right? So infecting agent, right, localizes in the epiglottis and the pharyngeal structures and causing swelling and obviously airway obstruction and potentially fatal. Okay, so some of the clinical manifestations is excessive drooling because they can't swallow their drool, they can't swallow their saliva, the saliva is going to come out. So drooling is a clear clinical manifestation of there being some sort of obstruction, right, at that level, or even in the esophagus, right? Refusal of food, odynophagia, right, or dysphonia, rapid onset of fever, right? Dynophagia, by the way, painful eating, right? Inspiratory stridor and retractions, oral pharynx, edematous and cherry red. So if you look into their, right, their pharynx in their throat. It's usually going to be very red and swollen, right? And then the child is kind of sitting in a sniffing dog type of position, which does provide the best airway. And this is very common outside of the United States, because, you know, the United States and other industrialized countries that vaccinate for the Hib, right, the Haemophilus influenza B, are not going to see this. But in other countries where that is not the common practice, you're going to see this entirely too often, right? So direct visualization of the epiglottis, right? And so thumbprint sign is the in the lateral x-ray is classical for diagnostic criteria for epiglottitis. You'll also see a CBC with leukocytosis with a shift to the left, which means getting and seeing a lot of new cells. So you're going to see a lot of immature white blood cells. That's a shift to the left. All right, so treatment is obviously, this is a medical emergency. You may have to have a child be intubated. Again, this is going to happen mostly in children with some nebulized adrenaline or epinephrine, right? And maybe antibiotic therapy to stave off the infection. And obviously, preventative is the Hib vaccine. All right, so croup, right, is a group of acute viral inflammatory diseases that are going to affect the larynx, trachea, and bronchi, which again can include laryngeal tracheal bronchitis, which is viral croup, and epiglottitis and bacterial tracheitis. Occurs very commonly in fall and early winter as people are starting to kind of get closer for the winter. So you start seeing it because a lot of people, when there's a winter, you will see them getting more clothing and they're being inside more rather than going outside. There's less movement of air in structures as everything indoors is heated. So those types of things can affect the way that different viruses are going to be transmitted. So you'll see that's why the flu is really, really bad more up north than it is here in South Florida. And we really get it in South Florida because a lot of the people who bring it from up north, where it's very common to see it in the winter months. All right, pathogenesis of your croup is right, it basically leads to edema in all of the subglottic area. So it's infectious, right? So it causes inflammation along basically the entire airway. So you're going to see upper respiratory infection type of clinical manifestations, barking cough with stridor, but no drooling. Okay, so no drooling in this case. So when you have the Hib infection, you're going to see drooling because that's often causing epiglottitis. This one may include epiglottitis, but without drooling. So it's a different infectious agent. Okay, so you might see epiglottitis again, but it's not as severe as it would be with the Hib infection. So severe cases, stridor at rest, retractions, and then cyanosis, right? So you'll see some lateral neck films with a narrowed or normal epiglottis, right? So this does help rule out epiglottitis, and you might see a narrowing below the vocal cords, a laryngoscopy, which also can help rule out the presence of epiglottitis, right? And then of course you're looking for those typical signs and symptoms of croup. Right, so mist therapy, oral hydration, right, avoidance of cough stimulation if at all possible, right, corticosteroids, oxygen therapy with pulse oximetry, which is basically the little thing on your finger to let us know what percent oxygenation you have, right, nebulized epinephrine, and endotracheal intubation if there's respiratory failure. All right, so a nurse is trying to decide if the patient has croup or epiglottitis. Which signs can help the nurse determine the patient has epiglottitis, right? I already told you, drooling is that #1 sign because you can't swallow the drool, and the thumbprint sign so that the epiglottis is so swollen that in the lateral x-ray, you're going to see the thumbprint sign. All right, so some diagnostic tests. So one of the most important diagnostic tests for all of the respiratory system is these pulmonary function tests, right? So they I'm going to help demonstrate where the obstruction, or that there is obstruction of airflow in the lungs, right? And then spirometry is going to help us determine the severity and diagnosis of the COPD. So spirometry is hopefully something that you already know, and so you already have the normal in your mind so that you can see what some of the abnormal ones might look like. So patient inhales deeply and exhales as quickly as possible until maximal air is exhaled, right? So forced vital capacity, which we've talked about, FVC, right, is the total volume of air exhaled. All right, so remember your vital capacity is everything you can breathe in above a normal breath. Remember, a normal breath is called tidal volume. So everything above normal breath until your maximal inhalation is called inspiratory reserve volume, right? And then you have your normal exhale, but everything you can exhale out beyond normal is called your expiratory reserve volume. Yes? So if you add up those three things, your expiratory reserve volume, your tidal volume, which is the normal amount that goes in and out during a normal quiet breath, and then everything you can breathe in, called your inspiratory reserve volume. So ERV plus TV plus IRV is going to be your vital capacity. How quickly can you exhale your entire vital capacity? So take a deep breath in and breathe it all out. What percent of that can you get out in 1 second is very indicative of your obstructive airway diseases, okay? So some of the other ones can be at different parts of your forced vital capacity, some to determine the, some smaller airway diseases, but your FEV1 with your forced expiratory volume in 1 second is that really is helping us with COPD. All right, so you can see here a little bit exactly what I just mentioned here with your vital capacity, your tidal volume. Your residual volume is the amount of air that's left in your lung to keep your lung inflated. You can't move residual volume unless your lung collapses. All right, so this is what stabilizes your alveoli, right? Your functional residual capacity, so FRC, is another one that's one of our capacities that's normal. Whatever is left in your lung after a normal exhalation, so nothing forced, just a normal exhale. So your TV, remember, is normal. So after your normal exhale on your tidal volume, everything left is going to be your functional residual capacity, which equals your ERV, your expiratory reserve volume, which you normally don't breathe out, and your RV, your residual volume, which you never breathe out. All right, so you can see here, forced expiratory flow rate, right? In the volume of air forcibly exhaled in a unit of time, so liters per second or liters per minute. So that's 25, 50, or 75% of your forced vital capacity. And your peak flow, right, is the highest rate of flow sustained for 10 seconds or more, which can be expelled from the lungs. And usually they have a little thing that you're going to attach to your lips, right, and then blow. That's called your peak flow meter. And your peak flow meter is going to indicate that number. And that number is going to be measured in volume per time. All right. So you can see here some pulmonary function tests, right? If it's greater than 75%, it is no significant obstruction. Between 60 and 70%, there is a mild obstruction. 50 to 60% is a moderate, and anything lower than 50% is a pretty severe obstruction. So you have a patient that can only exhale 50% of their vital capacity in 1 second. That means that they have the moderate to severe obstruction. All right, so you can see here some of the comparisons of our spirograms, right, or spirometry readings, right? So when we graph them, we call them spirograms, right? So normal is the NL, right? In restrictive lung diseases, see, you might see a 2.5 liters, about 83% in a patient, right, with a restrictive lung disorder, but the time, right, is going to be shorter, because remember, in a restrictive disorder, it's going to have a decrease in elasticity of the lung. So the lung is less compliant, okay? And then in a person with obstructive, right, if you were in my physiology class, when we did this in Biopac, I did it, you can hear me wheezing all the way up because I'm asthmatic. You can hear me wheezing for like 7 seconds, blowing air out. Okay, so even though I am not even having an asthma attack, you can still hear the wheezing. So you can see that obstructive person with that COPD go all the way out, still forcing air out. So you can force out the normal amount of air, just takes you longer. In a restrictive, you're not going to be able to force the normal volume of air out, and you're going to be limited on the time. All right, so spirometry, again, inhaled bronchodilator like albuterol, right, is given, and then you can repeat the test. If, right, you have an FEV1 that improves by greater than 15%, then you have a positive bronchodilator response, right? So remember, you can have patients with status asthmaticus. They may not be responsive to treatment at all, right? So indicates, right, a partially reversible bronchospasm of the smooth muscle. So you either have asthma or asthmatic bronchitis. Diffusion capacity, right? So that measures the ability of alveolar gas to diffuse into the capillaries, right? So it's obviously very valuable for determining, you know, some type of fibrosis or destruction of the membrane, like you would see in an emphysema. And then total lung capacity, right? So if you have a normal residual volume to TLC, right? Total lung capacity of 30 to 35%, right? That's normal, but if volume is composed of FVC and residual volume. So remember, your total lung capacity is going to be your forced vital capacity. Remember, with vital capacity was IRV plus TV plus ERV and then plus RV. So those four things together make your total lung capacity. So your normal RV, right? So residual volume divided by TLC times 100 is going to be 30 to 35%. So if it's anything greater than that, that means, remember, that it's either restrictive or obstructive, because that means that your residual volume, it's going to help you determine whether it's one or the other, because your residual volume is going to be greater. All right, so I was talking about this really quick. I wanted to go back to this picture, because you can see here in the person who has a restrictive lung disorder, notice that the volume, right, that you can move is going to be lower. So that means that the residual volume is going to be greater. All right, so diagnosis of an obstructive disorder is when they have a decrease, right, forced expiratory volume, or an FEV1 FVC ratio that's less than 70%. Right? You might also see an increased residual volume. You might see increased functional residual capacity as well, right? And so improvement after FEV1 of a, you know, after use of some sort of bronchodilator can help give a positive, like asthma or asthmatic bronchitis, can lead you in that direction of that diagnosis. Oxygenation and acid-base status are from your arterial blood gas, right? So your arterial blood gas is going to tell you what % of your blood is oxygenated. And again, you have to get that from your artery. So it's, don't go to the veins to try to get this measurement. So you can see here some of the normal, right, parameters, right? So you have your partial pressure of oxygen, partial pressure of carbon dioxide, right? pH, bicarbonate. And if this doesn't make no sense to you, then you need to go back to your carbonic acid buffering system and review why carbonic acid is going to be involved and why pH might be decreased. Okay, and then % oxygen saturation, which is decreased. All right, so also bronchial provocation tests, right? So you might right, inducing a bronchospasm by inhaling various agents, right? So allergens or histamine phosphate solutions, methacholine, nebulized distilled water. These things can basically identify hyperreactive airways, right? Obviously only done, right, with emergency support services available. And then the antidote would be albuterol or a metaproterenol, right? So hyperactivity is an FEV1 that falls greater than 20%, and then you stop the test. Right, so a patient develops symptoms during a bronchial provocation test. Which medication should the nurse be prepared to administer? Right, so we want to block something that stops the allergic reaction or the hypersensitivity reaction. So allergens, histamine, and methacholine, all are going to trigger it. So albuterol is going to help block it. So this is the end of chapter 22 that I was unable to finish. So I'll come back with chapter 23 in a different recording.